From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing pediatric concussion. I'm joined today by Dr. Sonal Shah, who is an Assistant Professor of Pediatrics at Harvard University, where she is an emergency physician in Boston Children's Hospital. Dr. Shah is an author of our Rational Clinical Examination article on pediatric concussion, which appears in the April 6, 2026 edition of JAMA. Dr. Shah, thank you for joining us today.
Thanks so much for having me, Dr. Simel. It's an honor to be here.
Well, let's get right to it, because all of us recognize that a concussion is caused by a direct or indirect blow to the head. But what's actually happening to the brain as a result of that force?
That's a great place to start, Dr. Simel. So when a child suffers an impact to the head, neck, or body, the brain can sustain injury in several distinct ways. Specifically in a concussion, the resulting impulsive force from the impact causes a mechanical injury to the brain's nerve cells. This results in ionic fluxes of sodium and potassium, and widespread depolarization occurs. These changes, combined with altered cerebral blood flow, create an energy demand mismatch, and this leads to inflammation, cytoskeletal damage, axonal dysfunction, and disrupted neurotransmission. And it's this disruption of neuronal communication, the alteration of cerebral metabolism, and the disturbance in cerebral blood flow that all come together to impair the complex networks that are involved in balance, vision, cognition, and mood. And that's what results in the complex and varying presentations that are associated with concussion.
Well, in your article, which is a systematic review and meta-analysis, most of the studies you found were among children aged 5 to 18, and the events where they suffered a concussion were sports-related. So let's say we're in a situation where we're at the field, maybe with our children, and we see a child have a possible concussion. What would we immediately notice?
I'm really glad you asked about this immediate on-field assessment. It's often termed a sideline evaluation. A substantial proportion of concussions are sports-related, particularly in adolescents, and those are usually a result of contact and collision between participants. And these injured players often undergo this sideline evaluation. So when someone is evaluating the acutely injured child with head trauma, there are a few red flags that you want to check for immediately. And if any of these are present, the child should be immediately removed from play and should undergo urgent medical evaluation. These red flags are actually outlined readily on the Sport Concussion Assessment Tool, or SCAT-6. And there's a long list of them, which includes neck pain, seizure, double vision, loss of consciousness, any notable weakness or report of tingling of the arms and or legs, an observation of deteriorating consciousness, vomiting, worsening or severe headache, worsening agitation, deformity of the skull, and finally, a Glasgow Coma score of less than 15. Those are some of the red flags that require urgent intervention. And then, the SCAT actually outlines these observable signs, which also warrant removal from play and prompt evaluation. Those include the patient who's lying motionless, if they've struck the surface without protective gear, if they've had an impact seizure, if there are any observable balance, gait, coordination, or general motor difficulties, if they're disoriented or if there's any type of mental status change like a blank or vacant look, significant facial injury, or a high-risk mechanism that's usually defined by an observed impact. If any of these exist, to reiterate, the child should be removed from sport and assessed by a healthcare professional.
Dr. Shah, you used the term impact injury. By that, do you just mean a typical blow to the head, or does that convey something else?
No, that's right. Just the force with which a child is struck in the head can vary. And so I don't mean anything more specific than that.
Well, the other setting where we may see a child with concussion, besides on the field when we witness it ourselves, is in a clinic or emergency room when the child is brought in to us, say, a few hours later or maybe the next day. At that point, what symptoms are most useful for evaluating the child and determining whether they can return to play?
I'm so glad you asked about that, because this is likely my favorite set of findings in the study. And that's because we get to translate our findings directly to the bedside in a way that makes practical sense. When we look specifically at time since injury, we were able to highlight some important patterns. The presence of light or noise sensitivity, nausea, dizziness, drowsiness, fatigue, and headache, all of which we found to be associated with concussion, were even more specific or had more accurate positive likelihood ratios for concussion diagnosis when they were reported 1 to 3 days after injury compared to reports of their presence up to 2 weeks later. And so these symptoms being present earlier were much more meaningful for concussion diagnosis. And when we examined the data even more closely, we were able to identify that the presence of headache within 24 hours of injury was highly suggestive of concussion, while its absence in that time frame really made concussion unlikely.
What about the physical examination signs?
There was no single finding, sign, or symptom that confirmed the diagnosis of concussion. Ideally, as clinicians, we develop a level of suspicion or a pretest probability for concussion, and that's informed by the mechanism of injury, which tells us about the force or impact transmitted to the head or body, and the signs and symptoms that developed immediately after the injury. We then take a thorough history and perform our physical exam. And consensus guidelines recommend that we assess the multiple domains. And those include balance and gait, cognition, vestibular, ocular motor function, neck injuries, and psychological or affective symptoms. Among the exam findings, we found that ocular motor abnormalities were most strongly associated with concussion. And that's actually really satisfying because these are quick bedside evaluations that can be done in most clinical settings and really help guide concussion diagnosis. So there's 3 ocular motor abnormalities that we identified to be strongly associated with concussion. The first is near-point convergence. And this is a quick assessment where you hold an object at the patient's eye level from about 2 to 3 feet, and you advance the object towards the nasal bridge of the patient and record the distance at which the patient reports double vision. They could also report provocation of symptoms such as headache, dizziness, or nausea, or you might observe ocular misalignment. An abnormal near-point convergence is considered greater than 5 to 6 centimeters away from the nasal bridge. Then there's smooth pursuits. So abnormal smooth pursuits are detected by having a patient track an object horizontally and then vertically with their eyes only, keeping their head still. So again, the visual target is held about 2 to 3 feet in front of the patient, and the target itself is moved smoothly from side to side over 2 seconds while the patient tracks with their eyes only. Observations of disconjugate gaze, catch-up saccades, or provocation of those same symptoms, headache, dizziness, nausea, are considered abnormal.
What are saccades?
Saccades are those quick eye movements that allow you to shift your gaze from one object to another. In an exam, saccades are assessed by asking the patient to rapidly move their eyes between 2 stationary visual targets while keeping the head still. And we can evaluate speed, accuracy, and symptom provocation.
Okay, so how do you evaluate balance and gait, which was one of the other domains you mentioned?
So balance and gait is typically assessed through measures of coordination, ambulation, and postural stability. And postural stability is really the ability to maintain stability while standing for 20 seconds with your feet together, hands on your hips, and your eyes closed. When we're trying to assess balance and gait, there are several options. We can directly observe ambulation. We can have the patient walk in tandem, so that's just heel to toe. Or we can assess dual task testing, in which a patient can ambulate while reciting the months of the year backwards, for example.
So if a child has an abnormality, a balance and gait, or vestibular and ocular motor function, a couple hours after the concussion, what is our response as a clinician?
The first thing is to remove the child from sport. And then the most important thing is to have them see an expert in concussion or someone who's trained in a complete multimodal assessment of concussion. And that multimodal assessment can be performed using the SCAT-6 that I mentioned earlier, and that can be used in children as young as 13. For children who are 8 to 12 years of age, there's a child SCAT-6 that can be used. And the SCAT-6 provides a standardized or structured assessment of children with suspected concussion, covering all the domains that we mentioned earlier. It does take about 15 minutes to complete, and it should be a quiet setting in which it's performed. It's most useful within 72 hours of the injury, and as I mentioned, it should be performed by a clinician who's trained in administration and interpretation of the SCAT-6.
A link to Dr. Shah's manuscript is in this episode's show notes, where you will find reference to the SCAT-6 and Child SCAT-6 available for download and use in clinical care. Dr. Shah, you noted that for most children, full recovery recurs, but symptom resolution may take up to 4 weeks. On the other hand, about 30% of children have symptoms that persist lasting longer than 28 days. So when you're thinking about return to play, what types of symptoms might still be present that need to resolve?
Yeah, determining when to return to sport is really crucial in a child's recovery. And that's because we really need to balance physical safety with the psychological consequence of prolonged rest and being out of their sport. So once a diagnosis is made, a decision to return to sport should involve a clinician who's trained in concussion management. And so we found that return to play decisions, which are usually made greater than a week after injury, should include 3 particular assessments as part of a comprehensive evaluation. And these 3 findings showed strong association with concussion greater than 1 week after injury. The first is reaction time during dual task performance, which was measured a mean of 7 days after injury and showed a strong association with concussion. A normal reaction time in that time frame made concussion less likely. So a quick way to measure reaction time is to have the patient walk while they're wearing headphones, and then they should identify the pitch of a noise that's played through the headphones, either high or low. And you can do this using an app. There are more simplistic, less technological ways to have them do a cognitive task and test their reaction time. For example, you can have them recite the months backwards and then drop an object between their fingers and see how long it takes them to catch it. But something like that does take a little bit of math to calculate the reaction time from the distance fallen. We also found that visual motion sensitivity, which is the development of dizziness, nausea, or headache during exposure to moving stimuli, like scrolling on a phone or riding in a car or walking through a crowd, was associated with concussion when measured 9 days out from injury. And finally, the balance testing that we mentioned earlier, when it was performed 11.4 days after injury, it was strongly associated with concussion. So persistence of any of these symptoms would suggest that the child should remain out of sport until they're back to normal.
What type of psychological or affective symptoms can you see?
There is a huge range of psychological symptoms that can develop after concussion, and it's important to keep in mind what the child's baseline is. From our study, we found that sadness and sleep disturbance were associated with concussion, but we could not show significance with those findings.
Well, what else would you like our listeners to know about the diagnosis of pediatric concussion?
I hope that the biggest takeaway from our study is that there are really some high-yield bedside assessments that most clinicians can integrate into their history and physical exam of an acutely injured child that can allow for concussion diagnosis with greater accuracy and confidence. And this will really allow patients to see trained specialists who can guide management decisions like returning to sport. We know that early clinical evaluation and timely management have been associated with improved recovery, including shorter symptom duration and earlier return to sport.
Well, thank you for joining us today. The manuscript contains links to videos where you can see the balance and gait assessment, the neck examination, and the oculomotor exam. I'm Dr. David Simel, and I've been speaking with Dr. Sonal Shah about concussion in children. You can find a link to the article in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.